Hi, this is Megan Edmonds, and this is my reflection in color.
Hello and welcome to the third episode of Reflections in Color, celebrating journeys to wellness. Today we have with us Megan Edmonds. She is a PhD candidate in social and behavioral sciences at Virginia Commonwealth University School of Medicine. She received her MPH, which is a Master's of Public Health from the University of Michigan with a concentration in health behavior and health education, and a Bachelor's in Psychology from Spelman College. Megan is a population health disparities researcher by training and doing quantitative, qualitative, mixed method approaches to assess breast cancer disparities to improve cancer survivorship outcomes in Black and underserved women. Megan has published research articles in health disparities in cancer survivorship journals. She's presented her research at numerous national level conferences, and recently, she was awarded an NCI Geographic Management of Cancer Health Disparities Program grant to examine racial disparities in breast cancer survivors' follow-up care. Megan, thank you so much and welcome to Reflections in Color.
Yes, thank you. It's a pleasure to be here. So thank you for having me.
The pleasure is all mine. Just going down your bio, you are a phenomenal woman.
Thank you so much. So we're also friends, and we met at one of those national conferences. So this is all love, and you're phenomenal as well. So I'm happy to be here to support.
Thank you, dear. Yes, so the cat is out of the bag. I do know Megan. We actually met at a Health Disparities Cancer Survivorship conference, excuse me. And we both study breast cancer health disparities. And it's something that I've discussed on my personal page as well as Minds of Melanin. And so I'm very happy to have Megan here to discuss her platform, Why We Survive, and we'll get a little more into that moving forward. So first, let's find out more about you. So the bio was short and sweet, but I'm sure there's more to tell. So first, who are you? How did you get into health disparities research?
So everybody doesn't have that sort of straight path, right? So, like everybody else, I don't either. So, I'm originally from the Midwest, Dayton, Ohio. And, growing up in the Midwest, many Blacks, migrated from the South, to Chicago, Detroit, Ohio area. And so, very heavily, predominantly Black neighborhood where I'm from. Don't get it twisted. And, what I saw growing up actually was many family members being afflicted with health, in a negative way, whether it was diabetes. Actually, my father had actually had diabetes type 2. And the complications, unfortunately, did contribute to an early term death. He was very young, wasn't even 50 years old. And so growing up at such a young age, seeing that on a more personal level, just kind of spiked my interest. Like, well, why don't we do better? Or can we do better? Is it a lack or something? I just always had questions growing up as a kid. And how did I get to research? That honestly is just like the sort of guidance of God, really, because I didn't even know what a PhD, what research was growing up, right? I just knew I had questions. So, and wanted to solve, So I can say, like, going to Spelman exposed me to a lot. I had my first internship at Columbia University in New York. I was a sophomore at the time in undergrad, so I was really young in this big city, not even 21, and was just exposed to so much, in the field of public health because I was interested in public health, right? Although psychology was the major, later I did add my minor in public health. And so that's sort of how I sort of trickled into the field, but it really just came from a personal sort of family motivational personal level where I just wanted to sort of make a difference in my own community and my own family.
Nice. I didn't know that about you. So
Yep.
one thing
Mhm.
about research that I've heard a lot in grad school is research is really research. So
Yep.
most of the research people do kind of stems from some type of personal experience. And
Right.
like you said, questions the person has about the mechanisms of whatever they're studying, how one became another. And so it's always so interesting to hear everyone's personal connection with their research because research is a labor of love.
Yes. Yeah.
Rough, but it keeps pulling you back. Something keeps you there because this is something that you're passionate about. It's a life work, basically.
Right. Yes. And I'm glad that you said that term, that labor of love. Like, that's what I consider my work today, honestly. I mean, how I sort of got into cancer research, my mother was diagnosed with breast cancer when I was at Spelman. And
Mm.
so as I'm figuring out, what to study in public health, or do I add this minor because it was additional coursework, right? Um, so I'm like, I don't know. But after the internship, I was sort of motivated. Um, but when I got that call, I'll never forget. It was my junior year, I believe. Yes, my junior year. And when I got that call, it was just sort of like, no, this is what I'm supposed to do. Like, I had no idea about breast cancer. And so it just became, sort of a road of personal sort of healing, right? Trying to learn more. So it was really a coping mechanism for me. I didn't realize that 10 years, 11 years later, I'd be still here doing this research, coping, but that's really what it started as. So it started as coping mechanism, and then I found out about all of these disparities. And what I mean by disparities is differences of health outcomes,
Mhm.
like dramatic differences, like white women are more likely to be diagnosed with breast cancer, but then Black women are more likely to die at all cancer stages, whether they are diagnosed earlier or later. And so finding these sort of, um, fine tooth, findings out about breast cancer just really sparked me more. And so it was a way of just, we want to make sure mom is good. So this is how I'm going about this process. And so, yeah, that's sort of how I got into breast cancer. So yeah,
Thank you for taking me down that trail.
yeah,
So before we go even deeper,
yeah.
I would like to have us pull apart some terms because we have a mixed audience. So you and I were kind of using our field language, but I want us to kind of break it down to make sure everyone is on the same page.
Sure.
So first, let's kind of start with public health. What is public health? Like health of the public, yes. But what does that really mean? What does that look like on a day-to-day basis as a researcher in that field?
Yeah, so public health is really everything that you see. It's our social surrounding, our environment, where we go to sleep, our home, where we live, our neighborhood. What resources do you have in your community? And so it really is not one thing, it's many, it's multiple, it's multifaceted. And so that's why within the field of public health, there's so many dimensions. You have behavioral, specialists, which is more about, the side that I'm on. Um, but that's not it. It doesn't stop there. You have environmental health, right? So what about the environment, our water that we're drinking? Is it safe? Within your community. And so also violence is another area too, right, within public health. So it's really ensuring the safety, right, and all of those social determinants of our health. Also the schools that we go to, the organizations, work setting, just so much. And also there is epidemiology, right, which is the field of studying diseases, the cause, the etiology, right, of disease. And so many, many, many parts of public health, but in a nutshell, it's all together, right? Because although there's different segments, we all are working for the greater the health of our communities, of our population, and that's sort of what public health is.
Thank you. So if I'm hearing you correctly, public health is how life impacts the health of individuals or of certain racial groups or other demographics, for example. So like you said, it could be your personal family, your school system, your work system, your neighborhood. the city, for example. So any dynamic of life has some
Yep.
kind of impact on our health. And what the field of public health does is kind of studies those relationships.
Exactly. How they relate. And I'm glad that you mentioned the sort of race component, because as we know, race is a social construct, right? Let's be clear. But in our country, there, it's systemic, racism, systemic structural factors that are embedded within really this country's structure. And so because of that, there is differential allocation of resources, right, within neighborhoods. And so that's how that sort of produces this production of inequitable health outcomes due to the environment and the sort of influences of our life, right? So just a little ad there.
Absolutely. Thank you. So, okay, now let's kind of dig in deep. Let's
Yep.
talk about research. So, why do we call it health disparities research? Isn't it just research, or is there some type of significant difference that requires that extra title change?
Absolutely. It definitely requires more effort. So health disparities research again is understanding the relationship of why a particular group, a particular racial ethnic group is less likely experiencing whatever that health outcome is. If it's, in terms of cancer, are they experiencing negative survival rates, right? Or lower adherence rates to mammograms. And so understanding why that is, so understanding why a particular group
Mhm.
of individuals have health outcome that is lower compared to the majority. The majority is white. And so whenever focusing on any minority focus group, and not just by race, like, because again, I think, in research, we race, but there's other social factors, right? There's our age that influences our health, right? Also, our neighborhood. I'm working on a study now where I'm looking at neighborhood. So it levels. And so there's just more than just race. Yes, race is definitely important to note, but I also want to just highlight the other social factors, education, again, insurance. That's more about access, but still just looking at other social factors and those influences on why a particular ethnic racial group is having a disproportionate outcome of a particular a particular outcome that you're studying within your research.
Thank you. Thank you for breaking that down. So, another thing I kind of want to focus on for health disparities research is we tend to compare racial or ethnic minorities or other social identity minorities to the majority group, which typically is white people or heterosexual people or middle class people, for example. Why is that? Are they really the norm? Like, what is the motivation behind using them as a comparison group?
Using white people as a comparison group. Well, as I've mentioned prior, the majority, right? So when we're trying to understand differences, or not even just differences, but why a particular group is experiencing, a level disproportionately difference, or sort of a lower rate of screening, for example. Well, if the majority screens, if the majority, sort of have a particular uh, direction of this particular outcome,
Mhm.
then it's important to sort of use the majority as sort of a reference group when you are studying the other minority group. And so there's some underpinning biostatistical, reasoning behind why um, whites are sort of the reference group, or sort of the majority when we are, looking at comparison or group comparisons in research.
Mhm.
And so not to be so technical, but that's just the standard protocol, right? That it's just standard. And so and it does make sense, in a common sense way, just to kind of like, okay, what does this mean? What am I talking about? So the majority is this, and so what is the other groups, sort of um, what factors do they have that the majority don't, or what factors, are contributing that the majority don't have. And so that's sort of again, the protocol and how we conduct research and how we understand disparities. But I will say that, it doesn't stop there. That's just the first step. Then you get into within groups within that group, right, that is experiencing these lower rates of screening, for example, or that are dying more from maternal, child labor, right? So just looking at those, comparison of white to black, that's just the first step, right? To just highlight there's a difference. This difference is not just a small difference, but this is a marginal twofold, threefold difference, right? So it's a big, big difference. And then we take it a step further on the second round after we've highlighted that difference to understand more about that group, right? Mm-hmm. Why Black women are more likely to experience adverse child, birth outcomes compared to others. So yeah, that's kind of the short version of researching how we look at disparities. But you do want to start with your Black to white, and then go into, okay, well, what about my group? What about age differences in my group? Because we have seen that. There's actually a paper that I published on, and we didn't see differences by Black and white. We actually didn't. So we're like, okay, so, but we know generally, right, we were using our own data set, but using national data sets, there is a difference in initiation of adjuvant endocrine therapy for breast cancer patients. Mm-hmm. So, but on our sample, we didn't see, they were like, So we took it a step further when we looked at age differences amongst Blacks and whites. That was our disparity. So Black women who were younger than age 50 were less likely to initiate endocrine therapy compared to white women and Black women who are older. So that was sort of the difference there, right? So it was an age difference versus just looking at race.
So in research, it sounds very complex. So not only are we looking like superficially, right? Like white, Black, Hispanic, Asian, Native American, etc. Just kind of see, is there anything across the board that we can just kind of see at glance? And then we kind of dig in deeper. What kind of Black women or what kind of Hispanic women or Latino women, right? And so we can get a picture of what we're really looking at to kind of figure out where do we need to step in.
Exactly.
Perfect. And I would also like to add, there is some historical relevance. White supremacy is one of the reasons why white people are used as a comparison group, because they were historically identified as the standard. And anyone who did not fall within that realm was substandard. And so on my end, within health disparities research, we often use them because it's to add context for treatment, for example, diagnosis, for example, because the only standard of training was within the white population. And now we have to add some information for non-white populations.
Exactly. And it's just feeling more to the story, right? Because for so long, this majority group, white people, have only been studied, have only been discussed, have only been used in, research studies, or, used probably isn't the proper term, but you know what I mean. That's just the fact, right? And so if we're trying to grow, research in other underserved groups and populations, minorities, people of color, and not just people of color, like even sexual orientation as well. Like, you got to compare, you have to look at what that majority is, because this is why this is important, right? Because compared to, right, so you're able to sort of, really advocate, for why there is a need to further investigate, further examine. And then that's how the monies, that's how you get your monies. When you're able to show that, factor there too, because it's like, oh, wow, this is something we haven't done before, or that is important. This is salient, right? Mm-hmm. So, yeah.
Thank you.
I'm glad that you brought that up, though, because it is historical, right, of why this is what it is. Yeah.
Exactly. And I'm glad that you brought up the monies, and we're going to get into that as to how that's relevant to research. So first, let's start digging into it for real. So we kind of laid the groundwork of what health disparities is, why it's important. So let's start focusing on breast cancer. I wore pink today, so did you.
Hey, don't get it twisted, okay? I know you got on red, and I'm like, I am the red, but this is actually fuchsia, and I have my fuchsia lip too. So yeah, we're doing it for the pink girls.
States we wear pink, and during Breast Cancer Awareness Month. So let's talk about breast cancer. Okay.
Yeah.
So we have seen all the ads, Race for the Cure, Walk for the Cure, 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 right? So within my fellowship with breast cancer, I had the opportunity to speak with their current diagnoses as well as survivors. And one thing they talked about was the lack of knowledge around research for breast cancer. And so one thing they said was, people always say like, well, we've been doing research for years. Why isn't there a cure yet? Mm-hmm. So I see you smile. The first question I would like to ask is, why isn't there a cure? How can you explain the limitations to a cure for breast cancer?
Yeah, that part, I have a biased response, and, but I got to be honest. I think, and this is a bit of my opinion and not more so on, empirical data from research, but, it benefits many organizations, pharmaceutical, our government, when people are sick, mm-hmm. right? Because mm-hmm. it just benefits, like they're able to have production, be able to produce, right? And so, it really comes down to the point, of something that I've, thought of is, okay, well, if these particular treatments are tied within the government or tied within pharmaceutical, then do they even want to cure? You know what I mean? Like, it's like, because we have gone so far with knowing so much and paying trillions of dollars in research over the years, decades. And so the only thing that continues to change, I can say, just now, this is referencing research, is there's been a lot of advancements in treatment for breast cancer in particular. So much. The reason why there is different types of adjuvant treatment is from research. So I'm not just talking about chemotherapy, but different types of chemotherapy. But I'm also mentioning endocrine therapy, right, which is a targeted therapy for specific subtypes of breast cancer, right? That's very clinically important for women who have those particular breast cancers. So again, like, the more people who are sick, the better, that sort of pharmaceutical conversation is, and the more hype, the more money that they receive. So I think, again, this is my opinion, but I have to be real. I don't really think that they're trying to find a cure. I think that it is a matter of managing, like, because cancer is a chronic health condition. So how can we manage? How can we better care, better deliver cancer care? I just don't hear cure talk no more, even within the field, and I'm in the field, right? We are in the field. So I think that this idea of the cure is just not the priority. Yeah.
Okay. I can resonate with that. Mm-hmm. I agree with you that our medical field is related to sickness rather than wellness.
Yes.
Right. So I definitely can see leaning one side. But empirically speaking, like you stated, there isn't just one breast cancer. And we don't do a good job of showing that there's a vast differences between the main types. And even within the main types, you have like subtypes as well. And I think that it's more intricate than it shows itself on the surface. So I think it's a dual thing. So one, our industry benefits from people being ill. But then two, this could also be something that is very, very challenging because it's so complex. Some of them don't respond to any of the medications, which is what my dissertation is on, triple negative breast cancer, where it kind of does its own thing. And it's unpredictable and it's aggressive and it's big as well, right? So I believe there's a lot of factors going into play. So I like what you said that we're kind of leaning more towards management now because we can't stop people from getting breast cancer. This is something that's happening and people are diagnosed literally every day.
Yes.
So now that we're here, right, breast cancer isn't going anywhere and we're focusing on management, I would like to run into your research, which focuses on survivorship.
Yes. Absolutely. So that's the passion there, and I liked how you spin what I said, to bring the light in there, which is the truth, and it provides more context to what I was saying as well. But I would also include too that even oncologists will say the same thing, and I've talked to many, and their focus is patient treatment
Mhm.
management management, you know what I mean, management, because they don't even say, oh, this is curable anymore when women are newly diagnosed. And I asked that, I said, well, I wonder why, because as a female, if I'm diagnosed with cancer, I would love to hear those words, right? But no, the actual correct term is your cancer is in remission, because cancer, if you have had breast cancer, the likelihood of it coming back is more higher. And
Mhm.
so that's sort of the transition into my research. And so it is personally motivated. But I can say just by firsthand, from my own experience, from witnessing my mother's reoccurrences, there was no sort of, you know, follow up care that was, focused on surveillancing the reoccurrence, right?
Mm.
So and I'm not saying this for a woman, who have had breast cancer. Oh, it's gonna come back, so you better make sure to have that heightened anxiety. No, but I am saying that it is important for women to surveillance to have follow-up care and to have that surveillance, because what we know from research, is that when women do not have that concordant continuity of care after going through treatment, so sort of post-treatment now is what we're talking about in terms of survivorship, is that there are many late effects from treatment, many late effects and adverse effects from those, as well as the possibility of disease relapse and not catching it early enough, right? And then that's when we get into sort of metastasized disease, where the breast cancer is no longer just in the breast, it's now in the lymph nodes, it's now in the liver, it's now in the bones. And so it becomes more of this metastatic breast cancer. And how sort of every national cancer organization discusses metastatic breast cancer is it is inoperable. And inoperable mean there is no treatment, there is no nothing. This is, you got to ride it out. This is palliative care, right? That whole talk. And so depending on who you are and who you talk to, there are different factors and elements that do contribute to uh, women being diagnosed at metastatic, right? And I actually recently was talking to a group of women. This was young women, young African American women, and I have to share the name of the group with you. But it was a young group of Black women who were diagnosed at metastatic. And so they are in their 20s, they're in their 30s, early 30s, and they were diagnosed, at metastatic. And so they're managing pain of cancer. So that's when, sort of looking at opioid, sort of management of pain. And so there's differences in cancer pain management. There's disparities. There are Black people are understood as having a higher pain threshold, so they're less likely to receive the adequate amount of cancer directed pain for opioids, right? And so there's just so much that's going on, in this context of cancer. But and I know I'm supposed to be talking about my research, but this is just hitting my bones, so I just need to say this. But that is sort of the sort of research trend that that I focus on. So I look at survivorship. Are women surviving? Unfortunately, Black women are not at all survival um, stages for the first 3 years, for the 5 years, 10 years, 15 years. Black women are less likely to survive at all of those stages. And so I focus on follow-up care. So how can we better address it? Looking at these devastating, you know, disparities for decades and decades, and it has been about 4 decades where we've seen this trend now for Black women in particular. It just keeps widening. So some factors to contribute to help close these gaps, to sort of mitigate, lower these mortality rates, is adherence to follow-up treatment, adherence to surveillance, whatever that looks like for that particular woman. And you said it, education. Many women who go through, you'll be surprised, many women who go through treatment, many women who are diagnosed do not even know about surveillance or sort of what follow-up care looks like after treatment. And a part of that is, I'm done with this, I'm moving on with life, right? Normalcy. And then there's also the other part of just not knowing. So, but whichever bucket it is, sort of a balance sort of is the, sweet spot, right? In terms of surviving and living longer. I said a lot, but yeah.
I'm gonna summarize.
Okay, thank you. Yeah, because you're good at that, girl. You're real good.
So survivorship, one is going to talk about that. So survivorship is women who go into remission. So that means their cancer is no longer detectable. Is that correct?
Correct.
Okay. And so the time marks, it sounds like, is it 1 year, 3 years, 5 years?
For survivorship? Yes, yes. You have your sort of early. So the early, we just, categorize it as the first 3 years, so early. And for women who have had a relapse in those first 3 years, the likelihood of it recurring again is higher. And so you sort of more follow-up, right, for that group. But yeah, like that's sort of what the language is now. It's remission. It's not even cure no more because of the higher increase of disease relapse. But there are many, 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 many women who have never had a reoccurrence, actually, 20 plus years, after having just one diagnosis. And so this is not, sort of the majority of women. Again, I am speaking from the perspective of Black women because that is the specific group that I study the most. Excuse me. So, yeah.
So what you shared was really interesting to me and a little surprising, if I can be frank, that there aren't a lot of follow-ups for cancer survivors because when my father had cancer, his was caught early. It was ear cancer, very rare. But they caught it early, right? Surgery, no chemo, we're good to go. He has had so many follow-ups since that time period. I am just impressed. It's like, oh, I'm going for my follow-up, going for my follow-up, going for my follow-up. And he didn't even develop to the point where he needed treatment. And so I'm surprised for a significantly more popular cancer, such as breast cancer, which is literally celebrated and normalized by so many organizations. It sounds like they're kind of dropping the ball. Like once you're cleared, you're really cleared and no one is giving you any additional thought.
Yeah, and I think really it's the focus, right? The focus really of, breast cancer. And what I mean by focus is sort of like, what are people mainly paying attention to? What's the priority? It's treatment, right? Prevention, which is definitely a priority. Don't get me wrong. That's definitely important. But there's this, excuse me, there's this continuum of care, right, for women who have been diagnosed, who have gone through treatment now, and unfortunately, there's just not that much attention and focus there. And that's where we're seeing these, alarming disparities. And the work that I'm doing about surveillance is only within the past 10 years of being noticed in terms of looking at disparities. And so it's something I didn't even know of, even like when I first started studying breast cancer. I was all about treatment, right? I was pushed into what the norm was, right? So women need to receive treatment. Okay, let's focus there. Women, you know, need to be understanding how to prevent, cancer and how to focus on prevention. And so I fell into that bucket too. So, I could say from my personal experience with my mother is how I ended up studying. My mother actually told me, right, Megan, I really think that you need to focus on follow-up care. My oncologist, they didn't say anything, right? And so my whole research topic is really informed by my mom.
Wow.
Yeah.
So let's go into that even deeper. So your research, you're focusing on follow-up care for survivors of breast cancer. How is your recruitment going?
Good. Yeah. So let's talk about the study. So the title of my study is, and again, it's not just a study. This is actually a movement. It's a LLC now. Um, so it's basically, I don't want to stop at research. I want to branch off and have educational seminars for women. We're actually in the process of developing our website. So, this is definitely something for the people. I'm not asking for money.
Mhm.
Many organizations do, but this is something that is informed by my research. And I just want to give it back to who it's supposed to be for, educating us. So the title is Why Women Survive Breast Cancer, and in short, Why We, acronym for Women Survive Breast Cancer. And I have been recruiting breast cancer survivors through an online survey. And I also have been conducting virtual focus groups with women who have participated in the study. And, when I will be honest, when I first started, I'm like, why am I doing this? Because recruitment was like, where is people at? I just wasn't nobody filling out nothing. So I was like, okay, this is that part where people say research is just slow.
Labor
So
of love, right?
it's
Labor.
labor. So, and this study started during my doctoral program, obviously. So it started last year, so 2019, early last year though. And I kid you not, I really did not start seeing a surge in, sort of recruitment numbers COVID, until COVID, really. And also, strategizing on my part with, reaching out grassroots to breast cancer advocates and organizations um, has also improved a lot. And so currently, I have a cohort of 250 women who have completed the survey. So I'm excited, more so excited about the findings and how this can provide, solutions and, sort of efforts to improve follow-up care. And so the sort of next phase of this project is to develop the website, which will be informed by my findings, and also to later you sort of test different messages to help promote adherence and sort of, follow-up care. And follow-up care is individualized, right? There are some standard sort of, follow-up protocols for breast cancer survivors if you have had certain surgeries that's sort of standard, such as lumpectomy, where that's just a removal of lump from either breast, or mastectomy, which is sort of, double mastectomy, removal of both breasts. And so there are certain, concordant follow-up per those surgeries, but it gets deeper depending on what type, like you've already mentioned, of breast cancer, in terms of that surveillance. But actually, every 3 to 6 months, women should be actually at their doctor sort of at follow-up within the first 3 years. So within the first 3 years after gone through treatment, you should actually receive follow-up routine care from your provider.
Wow.
And many women don't know that. One or two don't have that. I've talked to so many women during this project, and it has been certainly a labor of love. And I'm so happy about the resources I have now because I have help, because it was a team me for a long time. But I think that probably was where, like, as I was talking to women and them not knowing, like, wow, I haven't even done any follow-up. Let me get on that, right? So I just, feel like that sort of gave me more purpose, to just keep doing this, to keep getting the word out, because still today, many women, unfortunately, don't have that continuation or sort of communication with their oncologist or their cancer team in terms of follow-up care.
Question: do white women get follow-up care?
Yeah, I mean, it's for every woman, right? Not just Black women there.
So let me rephrase my question. Is there racial disparity in follow-up?
Yes. 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 So, in particularly, I look at adherence to surveillance mammograms. We focus so much on mammography screening. I mean, you're talking about there is several CDC initiatives just on mammography screening. Wow. Name one on surveillance mammography for survivors. It doesn't exist. So what we have found from sort of national data is that there is a disparity. Black women are always less likely to have had a follow-up routine mammogram compared to white. White women are always consistently higher who have, adhered to a mammogram. And that sparked my interest, like, again, I told you my mother was like, surveillance, follow-up, that's it. My mother had a mastectomy though, so she just wasn't even eligible to receive a mammogram, right? And so as I focused more, just sort of reading more research articles, like what is follow-up? Because again, I'm learning, right? I haven't even learned this on my training yet, right? So I had to teach myself so much, and it is sort of new. There's a lot of nuances, but this sort of, growing within the literature. But to date, there are 23 research studies that have identified racial disparities in surveillance mammography. And that to me was mind-blowing, because we know mammograms, is the staple for identification of breast cancer. So why are we seeing this delay, or maybe not delay, but why are we seeing this, non-adherence within Black women? And so that really is the focus of my research. So not just, so I say follow-up care broadly, right? But I do focus heavily on mammography. But again, every woman's follow-up doesn't consist of mammography. So then I open it up to MRI screening and sort of seeing your physician, regularly. And so other follow-up care procedures.
I didn't even think about that. For women who had a double mastectomy, what would their follow-up look like?
Yeah. Mm-hmm. That's what I mean by it being very individualized. And so the American Society of Oncologists, clinical oncologists, actually have standard, protocol for follow-up care based sort of guidelines, breast surveillance guidelines based on surgery. And so for women who have had, of course, a lumpectomy, they would receive a mammogram, right? Follow up, and they would receive it annually, whereas national, the recommendation is biannually for women. But for survivors, they should receive it annually. And the biannual is a new sort of recommendation that they've recently sort of made, because initially it was annually, right? But I don't agree with biannual, because it takes no time for cancer to progress. So I think, I I'm team annual. Team annual. Doesn't matter if you have had, you ain't had, team annual mammogram. So, okay, back to follow-up care. So women who have had mastectomy, actually, they can't receive a mammogram. Now, if they have had reconstruction, it's still no, mammogram there. And so they actually receive MRI screening, and they actually, have to have follow-up visits with their physician. So that's sort of the, where they're sort of looking for irregular, anything that can come up in terms of irritation with skin, any, pain that could start in anywhere in the body. It's very nuanced, right? And sort of, okay, we're looking at skin, right? So, right. So there's some things there that I'm like, this is not, this is not okay. And so I think, it's important also, even at the diagnosis, to understand those concordance or those differences and what follow-up looks like. Because if I'm a woman and it's so many nuances and a follow-up, I might not want to go with that, right? Because I'm thinking about, okay, I want to make sure that I receive good treatment from start all the way to follow up. And so no shade to mastectomy at all. I'm just saying that there's, it's harder, in terms of what the follow-up says, in terms of being able to detect a reoccurrence, which is why most women who have had mastectomy, when they do have a recurrence, it is late stage.
I had no idea this was going on. It's like a whole new world. And I'm
Yes.
oh.
It's so much. I've, you know what, girl, I've read so many articles. So if I'm over here talking too much, just stop me. Like, okay, girl, because I've read so much. And the more I read, I'm like, oh my gosh, it's just so many gaps. There's so many holes. And, actually there's even disparities in surgery. Like Black women are more likely to receive mastectomies, right?
Yeah.
It's more recommended by the cancer care team. It's the most radical, treatment in terms of breast cancer, right? That's the story, at least, that they tell you, but it's more to that story. And so I'm just here just to tell all sides,
I'm in awe of all the information that you hold, all the knowledge that you have about breast cancer disparities. I would like to shift gears a little bit though,
Okay.
and kind of pull out, because health disparities research is not popular.
Right.
So it's research that focuses on minorities. So assumptively, it's going to be a smaller population as well. With that, I assume there's challenges in conducting health disparities research. What are some of those challenges?
Just give me 1 second and some water.
Take your time.
Challenges with researchers, right?
Challenges with health disparities research.
Funding. In order to produce any research, on a volume level. What I mean by volume, the power that you have in what you say. So how many women did you survey? How many women did you speak with, or men? Matters, because numbers matter, right? And so unfortunately, less than 1% PhD researchers have actually received funding from National Institutes of Health. So, okay, let's talk about that. Less than 1%. What does that look like? It's definitely not the same for white researchers with PhDs. And that's again like getting into more of the historical context. For so long, we did not even have a PhD to study, right? And so the norm, white people, white men, white women, were the mass holders of, being a scientist and producing science. And so now, in today's day and age, of course, we have more diversity. more recruitment in terms of, being able to diversify the field of science. And so, yes, there's been many, advantages in science and Black scientists and just people of color in general. Um, but the facts is the facts. Less than 1% still today have received funding. And so it is challenging, and it is a stressor actually, for disparities researchers, because I mean, do they want to change their research topic? I don't even think it really depends on the research topic at this point, because that's just what the states are in terms of funding, right? Depending on, it doesn't even matter if it's health disparities. But when we look at health disparities, it even gets lower actually, which is something I never understood, because health disparities primarily, like, I mean, if I'm a funder, this is just my opinion again, I'm gonna give my opinion. If I'm a funder, I think, wow, like, I'm looking at applicants and I see a woman of color, a man of color, who've had a great track record of publishing and, accomplished, and look at another person and they have had extensive training in this particular diverse, health disparities research topic. And I'm looking at another applicant who is the European. They don't even have too much within this particular health disparity research topic, but wow, they've been funded. I'm going to just fund them, right? That's what we're seeing. Whereas this other applicant who knows the material, who really has been dedicating their whole career there, is overlooked. And there's different programs that NIH has, instilled to sort of boost, or sort of diversity, programs or fellowships to sort of boost, funding for minority researchers. And so there's some strides, but it's still a lot of work to still do. So those are sort of the major. I didn't really talk about the other challenges because I just had, look, I could just talk about funding forever, because that's how research is being able to be conducted when you have funds, resources, and so I'll just stop there. That's the number one challenge.
So thank you. You have to pay to play.
You do.
Right? So I think when people think about research, they don't realize how many things need to be paid for and how expensive research actually is. Right? So when we think about the PIs, that's a person who developed the study, they wrote the grant, submitted the grant, got funded, hopefully. Mm-hmm. They have a certain pay that they're supposed to receive. Right? And typically that's around, I think it ranged from like 100,000, give or take, roughly, depending on the size of the study and what the study needs. Beneath them, they have research assistants. And these are the people who actually conduct the study. So they call the participants, they run the experiments, make sure everything is flowing very well. They have to get paid as well. And they actually don't get paid as much. That can range anywhere from 18,000 to 25,000. These are typically graduate students. And when we start adding it up, a very seemingly basic study can cost anywhere from $250,000, right? And that's even with a limited sample, because you mentioned the power of it. It's one thing to say we had 30 people, and it's another thing to say we had 3,000.
Exactly.
Who are you more likely to listen to?
Yep.
And a study that has 3,000 participants is worth millions of dollars. It literally costs millions of dollars. So we put in the context of what these foundations are raising, what people are donating. It's not going as far as we think it is. Like, oh, we raised $10,000. That's the salary for one of the grad students, post-tax.
Exactly.
Right? And so funding, like you said, that is the key. If there is no funding, we can't even move forward. So let's say that we do have funding and we're ready to go, but we are in a situation like you were in before COVID struck. And that's when we don't have any participants. I want to dig a little deeper into that, especially for the African American community when it comes to research.
Absolutely. Yeah.
What are some of the barriers, in your personal opinion or clinical professional opinion, that results in Black people being less likely to participate in any type of scientific research?
Yeah, absolutely. So, I'm currently finishing up my PhD. So I fall sort of within that research, graduate research assistant. So I'm currently managing my advisor. She's a PI over a multi-million dollar grant. She is a part of the less than 1% who is funded. But managing her studies have definitely shown me, pitfalls, challenges when recruiting. We're currently actually recruiting women for one of her clinical trials. And, I have to say, I know you said pre-COVID, and I'm gonna get there, but because I'm currently, in the midst of recruiting women, now it is just safety. It's safety precaution, well, how long do I have to be, and so we're sort of now gearing towards a more virtual uh, trial of our particular intervention. This intervention is recruiting only African American women who've been newly diagnosed to improve their treatment adherence, as well as improving their communication to, you know, receive better informed care, right, in terms of deciding what treatment with their particular cancer team. And so it's a great trial, has shown many benefits. And when this trial was initiated 10 years ago, and so this is sort of the second time that this trial is going on. And there are some challenges again that we're sort of in the midst of, but historically, going to your question on, why are we seeing such a lag within Black particular population within research is mistrust, honestly. Historically, there's many cases I can just tell you, just from the field, where African Americans were literally lied to by scientists.
Mhm.
The Tuskegee syphilis case, for example.
Yes.
That is the truth. It wasn't false, it was the truth. And so these historical, events do play a role in the decision that, people have. And it's sort of free will, right? You don't have to participate, you don't have to receive this clinical trial. It's all voluntarily, right? But I can say that, it's still needed. And I think that you really just have to get the full picture, be informed. So when during that consent, in like the informed process, when you consent to participate, that's where you ask all your questions. That's where you make sure, okay, this is for sure safety. I'm fully considered. And so, because of those historical incidents where African Americans were lied to, not treated when they did have a particular condition or ailment,
Mhm.
there are current institutional review boards in place today at institutions that, every clinical trial, every research needs to be approved. Now, if that research isn't approved, don't participate. So that's, a little piece of, a tip. Make sure if you're going to participate in anybody's research that it has been approved by that particular institution. If there's no institutional approval, you might not want to participate. So, yeah, you can sort of trust the research process and talk to everybody, ask questions, just make sure that you're informed, because it's one of those things where, okay, historically this has happened. So I'm not rocking with nothing, right? But unfortunately that contributes to what we see today in terms of health disparities, right? It further contributes to another decade of survival disparities of African Americans, of minorities. And so it's important that we continue, the efforts of research and building our science within our own particular racial ethnic groups of minorities and Blacks, because that's how we're able to help us better. So, if you got questions, just ask all them questions to everybody on the research team, and then you can be informed. But I really think that the main contributor is, the history of research, and unfortunately, that's something that you cannot say didn't happen. It did happen, and, we're just trying to, focus on, how to work with what we know happened and, you know, empower people to, like, hey, we not about that. This is what we're on, you know what I mean? And you just really informing them. But also, African Americans are less likely to be asked to participate in clinical trials. And so that's also another challenge. They're not asked, they don't even know. And so that's another area too, on why that is. But, when information is discussed, maybe it's not discussed in a manner where they feel like this is something to really benefit their particular group. But when it is, they're more likely to actually participate.
Yeah. You touched on a few things that I want to come back to. One,
Yeah.
I highly agree with the tip that if you are interested in participating in any kind of research, ask questions.
Yep.
So before you enroll in any research study, we have what is called informed consent, meaning that you have been informed of what the study is about, the purpose of the study, what will be expected of you, and your rights within the study. Your rights will always, if it's an ethical study, will consist of you have the right to leave at any time without any penalty, because like you stated, it is voluntary.
Yep.
And that when you kind of go through the informed consent, lost my train of thought for a second. When you go through the informed consent, you want to make sure there's a seal there from the Institutional Review Board. So IRB, they're very important. They're the ones who review the entire study documents, anything that has to do with the study, including the flyers that they post to recruit people, how much they say they were going to compensate you for your time, everything.
Yep.
They have to approve it. So always ask, are you IRB approved? If no, continue on your way, because that probably is not a safe study for you. IRB is there to ensure that you will be safe and protected. And they're also there if you feel that you are not safe or protected. So if you are in a study and let's say they did what they need to do on the front end, but they're not holding up their end of the deal to conduct ethical research, you do have the right to call the IRB and report them as well. So they are there, in fact, to ensure the study is safe from the beginning to the end. So that's one point I wanted to come back to. So thank you.
Yeah.
The next point I wanted to come back to is the distress, the historical context. It's real. And I like how you mentioned that some researchers, they do have to kind of discuss that within the informed consent. On my end, I've definitely discussed that with people, their concerns about it, like, oh, what is this about? What do I have to do? And you can hear the fear, right? And it's valid. And that's something as researchers that I think we can do a better job of normalizing that process and not criminalizing that distress, because it has a reason to be there.
Right.
And I went to this one study, and the results were really interesting because it talked about relationships between researchers and communities. And I had the pleasure of being one of the evaluators of this study. And we wanted to know how the researchers and the community's relationships, do they enjoy working with each other? And one thing that came out of the study, I'll talk about two things. So the first thing that came out of the study is that it is a myth that Black people are not interested in doing research. They actually are. So like you stated, especially if it has something to do with benefiting their community, most of the time they are all hands on deck. Yep. And like you noted, they're just not asked. They just assume they wouldn't be interested. But two, the main part that came out of that study, and this is something I have carried with me as a researcher, is they feel used. So they say, we allow the researchers to come into the community and we do whatever they ask us to do under the promise that this research will benefit us. And they take that information, they leave. And they go to their conferences and they write their Scholastic Journal articles, and they speak with other like-minded people, and they continue on with their careers, and they never come back and use that information to make this community better. So as a researcher, one thing I will always do is I will bring that information back. So a town hall, for example, share the results, as well as have a plan. Because this research was done for a reason. It was put into action. And similar to why we survive, like you noted earlier, I have all this information and I want to push it out because it was for them. And that's what researchers really should do a better job of, because I think we tend to keep it to ourselves and our friends, and we go to our conferences, we read our articles and our didactics and our webinars, and we share it there, but that's not reaching the group who actually needed it and who participated and who deserve to know what this means in relation to their life. So thank you.
Absolutely, yeah. You have a nice way of summarizing that. So, but yeah, you hit it on all points, on all points. So yeah, absolutely.
So how does health disparities research in breast cancer connect with better outcomes for Black women?
Yeah. So when you're able to, you know, see the differences in treatment, for example, uptake or even uptake of genetic counseling, then you're able to sort of inform, next steps for interventions, for development of programs, for development of materials to educate, to be tailored, to the particular um, negative outcome that you're seeing those differences are with, and be able to, provide context to better produce, this particular behavior amongst this group. So, for example, the particular research that I'm doing right now, you know, is sort of informed from national data where we have already seen disparities in surveillance mammography amongst Black women when compared to white. Well, okay, well, let's look at this deeper, right? Let's really build this cohort of women that I'm, sort of looking at. And also, let's also have conversations. Let's have qualitative interviews, which currently there aren't any, regarding surveillance mammography in particular and sort of those experiences. So there are a few, I would say. So it's sort of like still just a few in this sort of conversation. So again, it just really provides, sort of the next steps to inform intervention development, to inform protocol, even for communication strategies, to improve, what are sort of what the campaigns say today. A lot of the campaigns around breast cancer are, screening, a little bit about particular chemotherapy pills, right? And those are really coming from the pharmaceutical companies, actually, that they have like on TV, like the actual commercials. And so there's real highly to say, well, there's not many campaigns or sort of commercial advertisements around, follow-up care or adherence to mammogram post-treatment and sort of what that looks like. And so that's sort of providing, the research that you do within health disparities and, in my case, breast cancer outcomes can inform, programs and communication efforts to really be able to, support a change. And what we know is that, from these large scale interventions or communication strategies, is that it does improve, behaviors. And so that's sort of the game.
Okay. Before I let you go, you mentioned genetic testing. What is that and why is it important?
Genetic counseling and genetic testing are two separate entities, but they're, within the same family. But it's so important, even if you do not do genetic testing, to do genetic counseling. So here's why. Genetic counseling is you simply having a session with a genetic counselor about your risk of breast cancer. This is for women or for a woman without breast cancer or women who have had breast cancer, to understand what type, sort of risk that they have. Is this cancer genetically um, informed, or sort of, maybe not informed is the right word, but is this genetic, cancer that is based on my genes, or is it just based on, there's different reasons why cancer can happen. And so for some women, it's based on hormones. So ER positive, HR positive, just hormones, right? They may not necessarily have a genetic based cancer, and actually um, only 15% cases of breast cancer are genetically arrived, right? And so it's not really that many cancers are genetic, just because we don't even know that much about genes, right? So the only genes that we're studying for breast cancer is BRCA1 and BRCA2. So when you receive, and there's several variations of genes, and so that doesn't mean that. It just means that that's just where we are in research, and so they're just looking for those two. And so for women who do have BRCA1 or BRCA2, the likelihood of them having cancer, breast or ovarian, is significantly higher, actually over 50%. And so for women who actually have that particular variant of BRCA1 or BRCA2, they actually have options to have prophylactic mastectomies, removal of ovaries, to sort of prevent onset of cancer. So we saw this example with Angelina Jolie. Her mother died from breast cancer, breast or ovarian, one of those. And so she went and received her genetic counseling and testing. So counseling is just you discussing sort of the context of what are my risks, and they're going to ask you questions, did your mother have breast cancer? Did your mother's mother? So just asking questions about your family, and then sort of putting you on a scale of possibly, it could be genetically, but possibly not. But Angelina Jolie actually received genetic counseling and testing and was confirmed BRCA1 or 2. And so that was her decision to take. She took all necessary steps. So she removed everything to not receive cancer, or to lower her risk of onset of cancer. And so it just gives you options, right? Now, for women who have had breast cancer, when women receive genetic counseling and testing, they're able to let their families know, like, hey, this could be genetically, of a risk for you, right? And so it's really important to educate the family, you know what I mean? Because, within the Black family, everybody knows somebody, right, with cancer. If it's not your family, then somebody's family next to you, or your friend, and so, if the family is receiving genetic counseling and testing, they're just more informed. They're more informed about risk potentially down the road. But it's not for everybody, but it's just an option. And so it's important, to be informed, to be educated about risk, especially before it happens. I've spoken to many women about genetic counseling and testing, and they received their information and they felt empowered. They wanted to bring their kids in. There's no age limit for genetic counseling and testing too, so anybody can receive it. So it's really just up to you, but again, knowledge is power, and I have saw families be able to make decisions early on, knowing their status of whether or not they've had BRCA1 or BRCA2 gene.
So what I'm hearing is this can not only be informative and empowering, but can also be life-saving.
Yes, absolutely.
Think about the health outcomes of Black women with breast cancer. It sounds like this is within their best benefit to consult, provided they have the lowest rates of screening, the highest rates of late-stage diagnosis, the highest rates of inconsistent treatment, and as you've noted, in or non-existent follow-up care. this may be one of the best routes to kind of get that process started, in addition to doing the other things that are typically pushed. So that is the home self-exam, the mammograms, and having conversations with your doctor as well.
Absolutely, absolutely. And if there's questions that you have about genetic counseling and testing, or maybe you're like, not really sure about the testing part, but let me just counsel. Let me counsel with someone just to see what are my risks, just generically, right? To just discuss with someone. It doesn't hurt to have those conversations. So just ask your provider, ask your OBGYN or your sort of physician, whoever you go see clinically, and just ask them to refer you to a genetic counselor. It doesn't hurt just to have the conversation, right? And then you can make that informed decision from after receiving counseling if you want to receive genetic testing as a next step.
Yeah. And I like that empowered notion, because one thing I've heard from several cancer patients or survivors I spoke to, they felt they had no power. They're completely helpless in the situation. And so with that information, to know that you can maintain some of that power and have some control over your life by genetic counseling, a simple conversation, like you said. I wonder why we don't talk about this more.
Yeah. Yeah, I mean, girl, there's many reasons why we don't talk about it. One, BRCA1 and BRCA2 was based on predominant white women, right? And so, again, like predominantly white women, make up the pool there. For example, like women in my family who have received, they didn't come up within BRCA1 or BRCA2, but they still had cancer. So it's like, okay, so there's some conversation there. But there's many Black women who have been receiving BRCA1 or BRCA2 confirmed tests. And so you really don't know. And so for some women, we had a focus group actually with women who did not receive genetic counseling. And then we had a focus group with women who did. And, there were some perceptions about, well, my cousin, she didn't have BRCA1 or 2, but she still had cancer, right? So I don't know why I need to put myself through the stress of going, to see, or, what if I do have it? And then it just adds more stress. And so it was just lots of different conversations that we did discuss. But, that's why I said it's not for everybody. But I do think that, the more knowledge you have, the more, you're able to make decisions, and you don't know your genetic makeup. So you won't know until you take that step. So regardless of what the predominant, group is and what it is, we all have similar genes to some extent. So, just knowing for you is important. But it does not state that, hey, I don't have BRCA1 or BRCA2, so my risk, I can't receive breast cancer. No, we're not saying that either. Because again, the majority of breast cancer is not even from BRCA1 or BRCA2, right? Genetically. So, yeah, it's just more to be studied there, to know other genes. And there's more research that's building about SNPs. This is me getting to my genomical research a little bit, which is growing. But there's a lot of research, again, like just with studying different biospecimen data, saliva, to test different SNPs, to see its association, and to know if there are other dominant genes for breast cancer. So we can extend, not just BRCA1, BRCA2, but other ones as well.
So there are a lot of questions that have yet to be answered.
A lot of them.
I once heard that cancer overall is like a black box.
Yep.
Because most of it is not genetically related.
Yeah.
And we still aren't quite sure where it comes from, right? We know that influences are, social, environmental, etc., but to pinpoint it, we haven't reached that point yet.
Yeah, we haven't. And so I always say, for prevention, you know, it's just better to just be healthy, right? Like not just to prevent risk of cancer, but to be healthy for you, right? When you're healthy, you feel better. And so drink more water, exercise regularly. The recommendation is that you receive 150 minutes a week.
Okay.
Really not
Here's the part
bad.
where I'm like, oh, not hitting that.
150 minutes of exercise a week. And it's like, oh my gosh, how many of us can just walk outside, for 15 to 20 minutes a day to get there?
Exactly.
And Black women have the highest obesity rates
Mhm.
in our country, and they're less likely to adhere to those physical activity guidelines. And so I just always say, look, I really strongly believe in the power of behavior and lifestyle changes.
Yeah.
I've seen it, you know. I just being transparent, I used to be borderline diabetic. That is something that does run in my family. And when I found out that I was borderline, like what and how they tell you is that you are showing signs, but you're not fully, right? So pre-diabetic is the correct term. When I found out I was pre-diabetic, I went on a complete drastic diet change, but it became my lifestyle, for example, right? I exercised more, and it was a very depressing state of my life during that time. And I just let things get out of control, but that's still no excuse, right? But given the pre diabetic condition, I changed everything. Glad to say I'm no longer pre diabetic. And, that's just my story, but I've heard many people who have changed their sort of chronic health condition around based on alterations in what you do day to day. What you put in your body matters. It matters. It matters. It totally matters. And so, really, the goal of my work, again, I focus a lot on breast cancer, obviously. That's the focus, but also understanding what lifestyle, changes or things that women do even after going through cancer, because this is a life changing, occurrence for women. And so what is the odds or likelihood of someone continuing, for example, smoking if they were a smoker after? And so, or, sort of physical activity. And so looking at those factors as well. But for every woman out there, I encourage you to really focus on improving any aspect of your health. We all can improve somewhere, whether that's eating more healthier, selecting more healthier options and drinking more water. So I'm an advocate of that all day long.
Thank you for those tips. So you just segued me into our last question. So you kind of shared that you have some personal connections with health disparities, as well as the work that you do. So how do you maintain your wellness?
Well, for me, it's about self care now these days. Self care for me looks like physical activity. I have a background in dance, and so I've always been active dancing. Now it's a bit different, obviously, with COVID. But I still provide that space because I know, like, I have to stay active. That's a part of me,
Mhm.
maintaining my wellness, and also taking space and time for me. What does that look like? Whatever that looks like on the day to day for me, as long as I'm doing that. And so, really prioritizing my self care. And it's something I did not do early on in my 20s and didn't even know what it was before then, right? But nowadays, that is my priority, and I'm happier. I have more joy when I'm prioritizing my health. And I just encourage every woman to do the same, every individual, period, because it truly benefits even your work life balance when you're taking care of yourself. And taking care of self is defined however you define it. But for me, it's definitely being active, dancing, what I eat definitely. So I go on different intermittent fasting, but it's really just my choice. You know I love food. I'm a foodie. So it's things that I have to do for self-control, okay? So, but again, that's me looking out for me. So, and knowing me best. And also just taking a walk outside is very therapeutic for me. I love connecting to nature, and having those different facets of my self-care really makes a difference mentally for me, but
Mhm.
also physically. So yeah, that's how I do my little wellness check, and it's working. I just got to stay consistent.
Yes, yes, consistency is key. Yes, but thank you for all those examples, making time for yourself and being flexible. Self-care can look different every single day. Sometimes it's watching Girlfriends on Netflix. Sometimes it's going for a walk. Another day is dancing in front of the mirror. It's whatever you need at that time to take care of yourself. So thank you so much. Megan, future Dr. Edmonds, come May. Thank you very much for your time. Thank you so much for the knowledge and education you provided today. I have learned so much from you, and I know the Reflections in Color audience has as well. Any
Yeah.
last words or comments? Anything we didn't hit?
No, just thank you for having me, fellow doctor. I am so proud of you, this platform, and inspiring many. Sharing, this information is monumental. And so just, blessings to you. And I'm happy to be a part of it. And in any way I can continue to contribute or support, just let me know. You have my support. And stay tuned for, more collaboration. And I'll just throw out, sort of my particular handles in terms of social media. I'm sure you'll probably include this, right? But but yeah, so if you have questions about how to participate in research that I'm conducting currently and working on, or just have questions, just want to know more, my contact handle is at Megan C. Edmonds, and my growing platform, Why We Survive, is at why.we survive. And it's a movement. Again, it's in the beginning stages, but it's growing beautifully. So please give it a follow and follow the movement.
Thank you very much, Megan. And again, Why We Survive on Instagram. If you are a breast cancer survivor, know a survivor, refer them, or if you even want to support. So again, research is a labor of love, and less than 1% of Black researchers are funded by the National Institute of Health. So if you have any donations as well, please feel free to reach out to Megan at Why We Survive. Thank you so much, Megan. Thank you, everyone.